Hello and welcome to a Health Podyssey. I'm your host, Alan Weil. Since its inception, Medicaid has covered the cost of nursing home care for those who are eligible and need those services. In the intervening years, there have been various efforts to shift care from nursing homes into the community through what Medicaid calls home and community-based services and what most people now refer to as long-term services and supports, or LTSS. Now, progress for what we call rebalancing has been slow, but it has been ongoing. Indeed, just a few years ago, CMS announced that more than half of Medicaid spending on LTSS was for home and community-based services, not nursing homes. Now, behind this slow but steady progress is a complex web of legal authorities, waivers, and state plan options that states can use to shift dollars and services into the community. Can we make sense of that complex web, and could we make the web less complex? That is the topic of today's episode of A Health Podyssey. I'm here with Allison Hoffman, professor of law at the University of Pennsylvania's Carey Law School. Hoffman and co-authors published a paper in the October 2024 issue of Health Affairs that examined the complexities of the current legal framework for providing long-term services and supports. We'll discuss that framework and what might work better in today's episode. Professor Hoffman, welcome to the program.
Thank you. I'm glad to be here.
So this is a topic near and dear to my heart, and I know to yours as well. So I'm really looking forward to the conversation. I think it's important before we get into sort of the legal structure and all of these other things that we just set the stage about what is the need for long-term services and supports among people who are enrolled in the Medicaid program.
Great. So let me offer a description of why Medicaid is so important and describe what it does for this population. So Medicaid is the number one payer for LTSS. It funds about half of the paid long-term care in the U.S., about $200 billion a year. And so when we talk about LTSS, we're talking about things like personal care, things like preparing food, eating, going to the bathroom, transferring from a bed to a chair, other things like adult day services when people go to get help elsewhere during the day, transportation. And so when we say that Medicaid is a number one payer for LTSS, that's not to say that it pays for the majority of the need. And I want to start with this point because most long-term care is provided informally, which is what we call care when it's provided by friends and family, usually, although not always, without pay. And so if we took all that care and quantified it, if we put a dollar amount on it, even if we put a very low wage rate, which is indeed what professional care workers make, informal care would be worth at least 3 times what Medicaid spends on LTSS. And so what is Medicaid? What is that piece that Medicaid pays for? It pays for LTSS when people are poor or they have functional limitations or both, often both. The criteria for how somebody qualifies is state specific. It varies based on the state. And the Kaiser Family Foundation does a lot of great research in this area. And they estimated that in 2020, about 4.2 million people used home and community-based services, and about 1.6 million people used long-term services and supports, LTSS, in institutional settings. About half of those people are over age 65. What surprises some people is actually half are under age 65. And so it's a small number of Medicaid's total enrollees. It's about 6% of enrollment, but it accounts for about a third of Medicaid's spending. It's expensive. And even though it's expensive, many people still don't get the care that they need. If you look at a number of people have studied wait lists, one report said that wait lists in 2020, people who are waiting to get services, those wait lists vary from under a year in some states to 14 years in other states. And around 700,000 people sit on those waiting lists. And that doesn't necessarily, it's an imperfect estimate in many ways. But the point is that even with this spending and even with what Medicaid does, a lot of people are still not getting the care they need, even after they start to seek it out.
Well, I appreciate you setting such a comprehensive context for the discussion we're going to have. Medicaid is both critically important and limited in who it serves. But for those who rely upon it, it's truly life-saving, life-changing, dignity-preserving if you can get what you need. You introduced term that may surprise people when you talk about waiting lists, because in sort of the popular imagination, at least among people who work in healthcare, Medicaid is an entitlement and wouldn't have waiting lists. But because of the way some of these services are provided, there are situations where waiting lists are formed. So that seems like a good turning point to sort of the heart of your paper, which is really only digestible, I'm sorry to say, if you read it, because there's so much richness there. But you describe sort of how we've come from a place where all Medicaid did was pay for nursing home services to now having significant support for services in the home and the community. As a lawyer, maybe the thing to do is to ask you to describe sort of the legal authority. How is it that a program changes from paying for one thing to another? And what's the role of the federal authorities as well as the state decisions whether or not to take up those authorities?
Great. Well, this question about the legal authorities and the complexity of them is indeed what motivated this article. So this article started with a project that was not that particular question, but it was an interdisciplinary research group at Penn that was funded by Penn's Leonard Davis Institute, and we set out to figure out how what Medicaid spends on LTSS, how it affects care worker labor conditions, how it affects wages, benefits, and things like that. But as we looked back and tried to figure out, well, how exactly do states pay for LTSS, and how has that changed over the time period we were studying? It was really challenging for us. And this is a team of people who know this program and who are reasonably intelligent researchers. And so one of our team members, Kate Rode, wrote a 10-page memo just describing how the authorities had changed over time. It began as an internal work product for the team, but then as we all read it and looked at it, we said, wow, this is actually something that could help others who want to understand this space and who want to do research in this space. And so to answer your question in a really broad way, you have to go back to the beginning of the creation of Medicaid. So I'm sorry to take you back many years, but you have to go back to 1965. And you had mentioned this in your introduction. At that time, nursing home care was the priority. It was deemed a mandatory benefit in Medicaid. And so what that meant is for states who wanted to participate in Medicaid, and when they participate, the federal government pays for part of the care, at least half, more in most states. For them to get that money, they had to include coverage for nursing home care for people who qualified. But if people wanted care at home, what has come to be called HCBS, or Home and Community-Based Services, that was deemed an optional benefit. States didn't have to cover it, most didn't. And then not long after Medicaid was passed in the 1970s, we started to learn that care in nursing homes was very expensive. Medicaid was spending a lot on it, and the conditions were not good. And so then the federal government started to create more options for states to do things differently. In 1975, it created something called personal care services, where states could pay for some care in their state plans, as part of their state plans. Not many did at that time. But then in 1981, things shifted. They shifted both in how these authorities were structured and also the amount that states were using them. So the Reagan administration created something called 1915C waivers. And states could use these waivers to provide HCBS instead of institutional care. And the Reagan administration did this largely because they thought it would be a less expensive way to provide care. And what the waivers did was they allowed states to offer HCBS in more tailored ways. They could provide it to specific groups of people or in particular geographies. And this 1915C waiver remains the predominant authority, legal authority, that states use to provide HCBS. Over time, though, other authorities were created, other waiver authorities were created, some were barely used, and 2 state plan authorities were added over time that allow states to add more HCBS into their state plans. The first came at governor's urging in 2006. It allows states to provide services to people who need less than an institutional level of care. And a second came as part of the Affordable Care Act. Neither of these have seen overwhelming uptake, but they're both there as tools that states can use. And so with all of, you mentioned this as well, with all of these different authorities, with the waivers, the state plans, the different ways that states can pay for HCBS, in 2013, Medicaid spending on HCBS surpassed that of institutional care. And this shift is sometimes called a rebalancing from care in institutions to care in home or community-based settings.
So I think it's important to point out one additional dimension that ties into your original comments when I asked you to sort of set the stage, which is the heterogeneity of the population served. So you mentioned it's a small share of Medicaid enrollees. You also mentioned that many people are surprised to learn the large share of them who are under age 65. So you have everything from frail elders with multiple chronic conditions who have difficulty performing daily tasks. You have people with traumatic brain injury or cerebral palsy. You have people with profound autism. You have people with serious mental illnesses, all of whom have different reasons for the limitations that they have in their ability to meet their daily needs. And so some of the different pathways you described, and as you noted, sort of the subdividing of the population, for better or for worse, was designed to take into account the fact that different people on Medicaid have potentially very different levels of need.
Yeah, for sure. That's definitely true.
I do want, because I asked you this question in the context of the waiting list, if you could just quickly explain to the audience how waiting lists can form under waiver authorities is different from what's possible under a state plan, just so that we at least close that loop.
Yeah, so the main distinction, if we think about state plans versus waiver authorities, the main distinction is that if a state provides a benefit as part of its state plan, it must be offered to everyone across the state who qualifies. So there would generally be no waiting lists in that case. If somebody qualifies, they get services. Under waiver programs, in contrast, states can limit enrollment. They can limit it to specific groups, as you're referring to. So they could, for example, choose children on the autism spectrum as a group that they want to focus on, and they can limit it to certain geographies. So they're going to create a waiver program for people with children on the autism spectrum in certain parts of a state. Or they could focus it for somebody with intellectual disabilities versus physical disabilities. So these waiver programs are approved by CMS for a set duration of years, and they're supposed to be then reviewed periodically, and if they're working, renewed. They also have to be budget neutral. It can't cost more to provide services in these programs than it would cost if that person were getting care in a nursing home. And so in these waiver programs, states can limit enrollment. They can put caps on enrollment. They could say, we're only going to spend a certain amount of money on this program. And then even if somebody would, in theory, qualify for that program, it is a child on the autism spectrum living in the geography of the state that is covered. If there's no slots left in that program, they have to then go on a waiting list. This distinction between state plans and waivers, I should say, has muddied a little bit over time, but it's the general distinction between the two. Now, you can imagine, Alan, that states are more comfortable. Why states use these 1915C waivers more is because when they add benefits to state plans, there are greater possible spending implications. They can't create those waiting lists. So what they add to the state plans tends to be skimpier than what's offered, the services that are offered through waivers, where they can control the cost. So there ends up being a trade-off in practice between the breadth of the eligible population covered and the intensity of the services available.
Okay, so you've outlined for us really this evolution, and at least provided us with the framework of the types of authority that exist. I want to talk sort of about how this has evolved and really move into what the implications are and how we might improve the situation. We'll cover those topics after we take a short break. And we're back. I'm speaking with Professor Allison Hoffman about the legal framework for Medicaid home and community-based services that provide people with long-term services and supports. Thus far, we've really sort of described the overall structure. I want to walk a little bit through how things have evolved and get a better picture of why your colleague had to write this 10-page internal memo describing the complex situation that we find ourselves in. Before I do that, I do want to ask you about the Olmstead decision. I think for many people, that court case was the first time they were really introduced to the notion of the mismatch between what people were being provided and what they really needed. And then, of course, the court created a legal obligation for states. But it's not the only factor in the evolution you've described. I wonder if you could just give our listeners a sense of that decision and sort of how it fits within the legal framework that you've
Sure, yes. This is comfortable ground for a law professor. So the Olmstead decision, I talk about it in the article as an accelerant. It came in 1999. And so as we've already discussed, nearly 2 decades before Olmstead, the federal government was creating these waiver authorities for HCBS, and states started to move care out of nursing homes, largely because it was an expensive way to provide care. But what started happening throughout the 1980s was increased attention on the deplorable conditions in nursing homes. And we saw a rise of activity by civil rights activists focused on nursing homes, and also by budgetary hawks who said they were really expensive, to challenge the reliance on nursing homes. And so this kind of movement, there were a lot of legal cases moving through the courts, but it culminated in the Olmstead case. And the Olmstead case was a legal challenge brought by 2 women with intellectual disabilities and mental health conditions who were institutionalized in psychiatric wards. And what they said was putting us in that placement in psychiatric wards is a violation of my rights because I could be cared for in a community. In the decision, Justice Ginsburg wrote for the court, and she agreed, she said that undue institutionalization is discrimination on the basis of the Americans with Disabilities Act of 1990. And so with that decision, there was more pressure on states to move people out of nursing homes and into what has been come to be called the most integrated setting possible. Integrate people into communities, integrate them into home-based care where they can engage more fully in life around them. And so in response to that, states expanded their waiver programs. You can see like an uptick in waivers in the years following the Olmstead case. And they also called at this point for new state plan authorities so that they could offer benefits statewide and not have to go through this application process. And so that's actually what led to the creation of the 1915 state plan authority, which allowed states to start doing that. Although still it's only used, decades later, it's only used in 13 states. So Olmstead really should be seen as a turning point, but it didn't create this trend. It accelerated this trend in Medicaid paying for HCBS. One other thing I'll note is that we talked about waiting lists earlier, and I taught this decision again last year in a seminar I was teaching on health and disability. And there's language that the states often use and the federal government has used to know that states are doing a good job in complying with the decision. And it's that, waiting lists are moving at a reasonable rate. And that language, which has become really important from a policy perspective, was in a piece of the opinion that was dicta. It wasn't actually the holding of the case. It's a suggestion that this is one way we might measure these things, but it's become something really important that we actually look at as policy analysts and that policymakers look at to say, hey, state, are you doing a good job of complying with the ADA and its interpretation under this case?
So the idea here is that if you solve this problem by creating a program and then put everyone on a waiting list and they never get off it, you haven't really solved the problem at all.
That's right. That's right. You're not doing a good job of looking for, that most integrated setting and moving people into it. Okay,
so I'd like to sort of turn now to what's behind your sense, and it comes through very clearly in the paper, that this is just sort of chaotic and fragmented and a patchwork, various terms that one could use. You've described to me the addition of new authorities. I wonder if you can give me a sense of sort of how much there's added, how much is taken away, how much do states go down one path? Do they choose different paths? Just to try to paint a picture for our listener of why it is you see the situation as so fragmented.
There has mostly been addition over time. There have been a couple of authorities added that really weren't used. And so some of those have been removed, but mostly it's been an addition of authorities over time. And what I think is interesting, and people should look to the article for this, is that we mapped out which states are using which authority. And if you look at those pictures, there's one that shows how states are using these state plans to provide benefits, and another one which looks at how they're providing waivers. And you study that, you'll see that there's no rhyme or reason. It's not that large states use more, small states use less, or blue states use X and red states use Y. It is a random mix of use of these kinds of authorities across the states. And there doesn't seem to be any rhyme or reason as to why certain authorities are used in certain places and not in others. It might be that if researchers spent a lot of time studying these things, some of those lessons would actually emerge. But we don't know, looking at this map, that what Pennsylvania is doing is effective, and what Wyoming is doing is less effective in terms of meeting beneficiaries' needs. So it's been this accretion. It's been the federal government putting more things out there to states to say, hey, try this, use this, and then different states taking up different authorities over time based on, I can imagine, a whole host of elements: how much the state wants to pay for care, what the constituents, interest groups, and persuasive voices across the states manage to advocate for in state legislatures, what the federal government offers in terms of taking up these programs. But we don't really understand what's working, what's not working, and which of these things we should invest in more.
So maybe you've anticipated my next question, but part of when I listen to you, I say, okay, we're trying to rebalance. And, what's the first thing every governor says? One size doesn't fit all. Yes, there's been an accretion of different authorities, and fine, state A thinks this method works and state B thinks that method works. And at least we've given them the tools. Why would you take them away if that's moved us in the right direction? You did, just in the end of your last comments, talk about how difficult it makes it for researchers and trying to figure out what works and doesn't. And that seems, of course, as the editor of Empirical Journal, that's of great concern to me. But I wonder if you could also describe any other implications of this patchwork.
There are so many interesting implications of this patchwork. So let me describe it from the perspective of a few different groups, not just from researchers, although, of course, that's one of the lenses that I look through. So one of the things I found interesting, Alan, is as I've talked to people about this work, a number of people who work for state Medicaid programs don't really understand the programs in their states. It is a complicated picture for everyone, including people who study this stuff and think about this stuff. It's complicated for the federal government, for the states, for the researchers, and for the beneficiaries. So I live in Pennsylvania. Pennsylvania has 7 1915C waivers, and I pulled up one of them recently just to see, what does this thing look like? What I pulled up was the agreement between the state and the federal government. It is 500 pages of dense data and details. Maybe somebody who's listening to this today, has to go through and update that document every 3 to 5 years, and has to do the same for all of the other waiver programs across the state. That's taking a lot of effort and money and spending on an administration instead of on benefits. CMS, has to do the same, right? Then it has to review those waivers. And even with this kind of record keeping and reapplication process, CMS wrote this really explicitly in a regulation that passed this year, lamented that there are disparities in these programs, and even more, the lack of data to understand these disparities. CMS explained that most states lack the data infrastructure to track and report what's going on in their programs, which prevents the states and CMS from improving these programs. Sometimes we think, like you suggested, that this is allowing states to tailor things in ways that really work for their populations. And CMS says, well, our hunch is actually it's creating disparities that we don't understand. And so then it comes down to the enrollees, right? So the enrollees have to navigate this kind of complexity. Medicaid is hard for people to navigate from the get-go, even when it is an enrollee who does not have disabilities. So I included a quote in the article from Jamila Mishner's book, which is from an enrollee who is commenting that it's a lot of work. She says many times it's a lot of work. The state creates a lot of work for us to qualify for benefits. And studies have shown that that's really the case when it comes to HCBS. The multiple authorities that are out there are confusing for beneficiaries. They have to go through and often apply to multiple programs at once to try to get the care that they need. For each of these applications, somebody has to go through financial assessments and functional assessments to determine whether they qualify under the state's particular terms of who gets care under X waiver or Y waiver. And these are people who need help with care. So can you imagine somebody who has just had a stroke and needs to get care quickly, and instead they, and undoubtedly their families, because a lot of this work is done by family members, are having to wander through this kind of bureaucratic maze. So if you lift this up at the meta level, what does that create? We don't really know, right? That's what CMS is saying. We don't really know, but we know a little bit. We know that there's geographic disparities within states. So for example, I cite a story that in a study that shows in Michigan that 10 counties house more than half of the Medicaid population, but only a third of the waiver slots. So people in those counties are going to have a harder time getting access to HCBS just based on where they live. Across states, people in some states can get access to care, but they wouldn't be able to if they lived in other states. Beneficiaries often talk about how the benefits that they have access to in a state locks them in. They can't move from one place to another. And more research is emerging showing that there's that these mixes of authorities are creating racial and income disparities in access to HCBS, at least some of which is caused by the difficulty of navigating the system. So it's really hard to know why one person uses services and another doesn't. But for just one example, a study of HCBS autism spectrum waivers showed that higher income families seem to be able to navigate access to these waivers better than low income families. That's not surprising, right? So can you imagine if other Medicaid services were treated in this way? If, well child care, you had to go through a waiver program and jump through hoops to get that kind of care, we would be outraged looking at that lens through the beneficiary's perspective. And so one last thought, and this is kind of going back to the motivation of the study, which is don't forget the labor force. We suspect that these policies are shaping the availability and the compensation of care workers, but it's really hard to isolate any one variability to show that, for example, states that provide benefits through this pathway are creating conditions where caregivers are paid more versus states that are providing it through a different pathway. And this group is continuing, my co-authors and I are continuing to chip away at this question. We have another paper coming out that is led by Kate Miller, one of the researchers in the group, that shows that counterintuitively, increased investment by a state in LTSS is not obviously translating into higher workers' earnings. So why is that? Where is the money going? It's challenging to know. But this is some of the impacts of this array of confusing policies on the people who are using them and the people who are providing services that we suspect is, if we fully understood, we would be unhappy with kind of what this array of different authorities is actually producing on the ground.
Well, as we bring our conversation to a close, I want to try to figure out where to go with this. I'm sure I'm not telling you anything you don't know when I say that healthcare is filled with irrational, bureaucratic, administratively complex, and inequitable systems. I certainly don't want to defend them and say, well, we should just not worry about this one because it exists elsewhere. That's certainly not the right conclusion. But it's also the case that efforts to create uniformity bump into the problem that there are political and fiscal realities that, as you note, for example, when states do state plan amendments, they tend to be more restrictive because they're more worried about the finances. And the federal government presumably would take a similar approach. If it were to step in, it's not going to set the equal bar across states at the level of the most generous states. It would say we can't afford that. So short of sort of starting from a blank piece of paper and writing a new statute that is more tailored toward home and community-based services, and which is something, of course, that people have suggested we do, are there steps that you imagine or that you've discussed with your colleagues that could make improvements that would be worth achieving, even if we weren't able to eliminate all of the complexity and inequities that you've described?
For sure, there are lots of small steps we could take. But before I delve into those, I want to spend just a moment talking about why we see political and fiscal roadblocks and why Congress fails to address the underfunding of long-term care. And that is because it can, because when it does so, family, mostly women, step in and provide care without pay. And if we thought about that piece more, if we focused on that more, we might want to do differently. So it's very costly. One of my co-authors on this study, Norma Coe, is among the researchers who've done excellent work showing how informal caregiving pulls the rug out from under family caregivers. It creates intergenerational insecurity. And when I've written about this elsewhere, I've called these costs, the costs that friends and family incur when they're informally caring for others, the invisible co-payment of long-term care. Essentially, we've created this massive co-payment in our federal programs and our state programs, but it's a co-payment that's invisible because it's happening in households. It's hidden from our view, and so policymakers can ignore it more easily than they could ignore other things. We know it is possible to do better. So the U.S. underspends its peers on long-term care. That's, as you know, not the typical story about U.S. healthcare spending, where we spend, the Commonwealth Fund again told us this year that we outspend our peers on healthcare by about twice on average. Yet we spend less than peers on long-term care. We spend half as much as a percentage of our healthcare spending as, for example, France or the UK. We spend about 8% on healthcare, on long-term care. Countries like the Netherlands and Norway spend almost 30% of their healthcare spending. So this is not a question of insurmountable fiscal realities. It's a question of priorities and how we think about care obligation and who should provide it. And we have moments of doing better in meta ways. So during the pandemic, the federal government offered more money and loosened restrictions on paying family members who are providing that care. And 37 states took them up on it. They paid parents and guardians for providing services in the home. It was, unsurprisingly, it was expensive. And in response, as the federal government money starts to pull back, states are ending these programs. But that's a choice. That's a choice of federal priorities and state priorities. So my point, before I actually answer your question, is that policymakers do on occasion make big steps forward in expanding benefits and beneficiaries. The ACA's Medicaid expansion is a great example where Congress said, this is important. We care about it. We're going to put money behind it. And most states followed in line. And so I think it's to solve this problem, it's really time for the same kind of leap in how we think about long-term care, especially home and community-based services. Okay, now to answer your question, short of such a leap, any steps that Congress and CMS makes at this point should be in the direction of meeting people's needs in less complex ways. That's really where we get to at the end of this article. And so President Biden had proposed spending more on long-term services and supports. It didn't make it into the final legislation, but had it, what I would like to see is that additional spending is focused on transforming the program into something that is clearly meeting beneficiaries' needs in more simple ways. And there are lots of ways to do that. Some states have, for example, started to consolidate waivers. They're just simplifying the architecture with a focus on meeting beneficiaries' needs within those states. Another idea, and you talked about this a little bit, one that was proposed by the Bipartisan Policy Center, is create a base level of required HCBS services in state plans. Create some standardization. The risk, of course, is you want to create equity and access without a leveling down, and that's a delicate balance. So you would need to create ways for states to and encourage states to provide more on top of that base, but it would at least create some baseline of equitable access. Another approach would be increasing the federal match even more in the Community First Choice Program, which is the which is the state plan, authority that was created under the ACA, 1915K. And so the federal government said, we'll pay you 6 percentage points more on top of the normal federal match for your programs if you offer comprehensive services in your state plans instead of through waivers. And so this is a shifting kind of large scale of providing these services through waivers to state plans where they would be offered statewide to anybody who qualifies. So if I held the magic wand, if I were in charge, that's what I would do, is I would put more money behind the 1950K, the Community First Choice Program, and see if we could move more states to providing HCBS through their state plans. So, my point really is I don't think there's one singular right answer policy-wise. And we can see this if we look at those peer countries who spend more on long-term care than we do. They don't all do it in the same way. But the goal should be moving towards a system that reflects the fact that we've chosen HCBS increasingly over institutional care. And we should then commit a legal architecture that commits to paying for it for the beneficiaries who need it.
Well, I appreciate you not letting me paint you into a corner where all you could talk about was small ideas and incremental changes, because you're right. On occasion, we are able to take on larger challenges and make big leaps forward in addressing problems that we've let fester for a long time. But I do also appreciate you offering a roadmap of smaller bites that seem more realistic, particularly, as you say, something as programmatically simple, although not budgetarily simple, as increasing the enhanced match for an approach that would create more uniformity both within states and across states. Those seem doable in a way that maybe larger bites are not. But really, overall, I think you've done what I had hoped we would do in this conversation, which is describe a tremendous need, the fact that it's not being met equitably and not necessarily being met efficiently, even as we do see shifts over a very long sweep of history in the right direction. And I will end where I know maybe it's not quite right to end, but as the editor of Health Affairs, I have to say we do actually want to know which of these programs have the most positive effects on people's well-being and health and program costs. Those are important questions if we're going to expand and build upon them. And chaotic structures and differences that don't have much meaning get in the way of understanding what works and what doesn't. And so we shouldn't minimize that just as a research issue. It's actually a fundamental structural challenge that prevents us from making progress. Professor Hoffman, thank you so much for the paper, for explaining it and the context in which you wrote it. Thank you for being my guest today on A Health Podyssey.
Thank you. It's been a pleasure.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about A Health Podyssey.